How to use the head mirror. Adjust the headband to your size. Close your non-dominant eye and look through the hole at your objective. In this case, the ears. Then, open your eye and focus with both eyes. Position the lamp above and behind the patient's shoulder. Direct the light from the lamp onto the mirror and reflect the light onto your objective. You should now be able to use both hands freely and see the objective with both eyes. Inspect the external ear. Check for the size and shape, position, lesions, and discoloration. Palpate the external ear. It should be a non-tender auricle in tragus. Palpate the mastoid process for tenderness, temperature, and edema. Otoscope technique. Ask the patient to sit comfortably with the back straight and the head tilted slightly away from you, towards their opposite shoulder. Choose the largest speculum that fits comfortably into the ear canal, usually 5 mm in adults, and attach it to the otoscope. Hold the otoscope in your dominant hand and turn the otoscope light to on. Use thumb and fingers of your opposite hand to grasp patient's auricle firmly but gently. Pull up, back, and out to straighten the external auditory canal. Do not alter the position during the exam. Grasp the otoscope handle between your thumb and fingers. Hold the otoscope up or down, whichever is comfortable for you. Steady your hand holding the otoscope against the patient's head or face. Insert the speculum gently down and forward into the ear canal, approximately 0.5 inches. Be careful not to touch the inner portion of the sensitive canal wall. Position your eye against the lens. Inspect the auditory canal for the following: cerumen, appearance, tenderness. Inspect the tympanic membrane for the following: color, consistency, and visualizing landmarks like cone of light, umbo, malleus, and short process of malleus. Tuning fork test. To assess the auditory function, do the following tests using a tuning fork with a 512 cycles per second vibration. Weber's test. Place the handle of a vibrating tuning fork on the vertex of the skull. Ask the patient to indicate the location of the sound. If the sound was heard equally loud in both ears, this indicates intact auditory function. Vibratory sound lateralizes to the poor ear in conductive hearing loss and to the good ear in sensorineural hearing loss. To differentiate the two, proceed to the Rinus test. Rinus test. Place the handle of a vibrating tuning fork over the mastoid process to assess bone conduction. Ask the patient to indicate when the sound is no longer audible. Once the patient can't hear the sound, immediately place the tuning fork near the pinna to assess air conduction. A normal response is that air conduction is greater than bone conduction, or a positive RINA. The patient can hear the sound when the fork is placed in the mastoid and upon transferring the prongs near the pinna. When the sound disappeared, the patient can still hear the sound. In a negative RINA, the patient can hear the sound when placed in the mastoid, and upon transferring the prongs near the pinna, the patient cannot hear the sound. Example: Weber lateralizes to the left. RINA negative on the left ear. Bone conduction greater than air conduction. Conductive hearing loss on the left ear. Weber. Lateralizes to the left. Rina. Positive on the left ear. Air conduction is greater than bone conduction. Sensory neural loss on the right ear.